It's indeed a great delight to be amidst you all lovely, warm ladies and gentlemen, and to share my views, thoughts, concepts, and passion. Every clinic in which you are there, of every diabetologist, is a sexual health clinic. As sexual dysfunctions are not just symptoms, they are not like a traumatic big injury or a cancer or anything anatomically different. We need to ask in our history, and little additions to what is not being asked today by you guys will convert your diabetic clinic into an additional sex clinic, which will make a wholesome clinic of yours. This is at the moment, but once you start talking about sex with your patients, this is what it will be. The key is not to prioritize your schedules, but to schedule your priorities in life, which is being healthier and happier, not only yourself, but also giving that quality of life to your patients. The commonest complications in men in diabetes is erectile dysfunction. 82% of men in India don't talk about it. They live in silence. I don't know why the lights are on. I'm not supposed to show any demonstration or anything. Dr. David Sinclair, a famous genetist from Harvard Institute, he wrote a book, Why We Age and Why We Don't Have to. He described beautifully certain hallmarks of aging, which include genomic instability, attrition of telomeres, alterations of epigenome, loss of healthy protein maintenance, mitochondrial dysfunctions, and so on. And if we are able to address these issues, you can slow down aging. And once you slow down aging, you can forestall diseases. And when you forestall diseases, you can push back death. So you can decide your death today. In my 3.5 decades of practice, what we have in our armamentarium to give to our patients with sexual dysfunctions do not help in preventing or curing these dysfunctions. They don't cover the etiology of these infections, which are these issues, which are mitochondrial dysfunctions, endothelial dysfunctions, and nitric oxide deficiencies. And the earliest marker of diabetes today is erectile dysfunction, be it in pre-diabetics or in diabetics, type 1, type 2. It's been proven beyond doubt. And it is said that ED is an earliest marker of myocardial ischemia. So because the penile arteries are the smallest arteries, and the larger than that are the coronary arteries. And the arteries, due to atherosclerosis, which affect first are the penile arteries, giving symptoms of ED. But these symptoms of ED will not, at that time, will not have, patients will not have any symptoms of coronary artery disease. And the gap is 5 to 7 years. So that important is asking your patients for sexual dysfunctions, particularly in those patients who have got metabolic syndrome, or those children of those patients who got metabolic syndrome. So in this next 30 minutes, I'm going to give you some nuggets of wisdom as to how you can establish a sex clinic in your existing diabetes. You don't need to have a big infrastructure like Khajuraho or anything like that. You just have you are having a sex clinic in your clinic itself. But all you need to is just change your mindset. Come out of that taboo issue and start talking to your patients. Ask them about it. So with pranams to God and thanks to my teachers, Dr. O.P. Kapoor, Prakash Kothari and Shashank Joshi, these are the mentors of mine and they've made me what I am today. My talk today is because every human being has a right to healthy and satisfying sex life. It's your right. I won't let my diabetics die in bits. We talked so much about intelligence, artificial intelligence can be artificial, but stupidity is always natural. So why think of doing something in AI? Why don't correct the stupidity which our patients have? Will be more beneficial to our patients. My objective is to make you understand that how sexual health and obtaining a compassionate and comprehensive history is important. How to set a stage of obtaining sexual history. What is the ambience you should have? What is the body language you should have? What privacy you should need? And learn what to investigate and manage sexual dysfunctions. This is my concluding slide. What an ideal diabetologist should do to establish a sex clinic in his own setup. Most important is prioritize. Because you're asking this small question about the symptom, and correcting it will give him longevity and good quality of life. So prioritize sexual health. Ask your patients, do you have problems in making love? In a very soft, sympathetic, empathic tone. Take detailed, comprehensive history and examine him from top to bottom. My teacher tells me I see 110 patients a day. I don't have time for all that. So I tell him, sir, you don't see 110 patients. 110 patients see you and go. How can you see 110 patients? You cannot. How much time are you going to give to your patients? You just see the reports, change HbA1c, this drug, that drug, this insulin, that's it. That's not he has come here for. Rule out psychogenic or psycho-behavioral issues. Leaflets can be kept in any languages on sexual dysfunctions. Motivational posters can be kept in the clinic. Equipments like orchidometer, Doppler, hand dynamometer, or advanced glycated end product readers can be kept in your clinic, which can enhance your diagnosis. Investigate lab work, hormone studies, sonography, Doppler studies, counseling on lifestyle measures to be adopted as soon as possible, nutritional intervention and counseling, mental health checkup is a must, and premarital counseling. Prescription of medicines can be there, but with cautions. Why? Because sexual medicine is a vast holistic specialty. It focuses on wellness. See, my patients don't come with breathlessness, with bleeding or with trauma. It's only they want to be well. They want to remain well. They want to not remain ill. And there are various routes into this specialty, and no single discipline has a dominance or exclusivity. Any psychiatrist, gynec, endocrine, all Rishi Vedas in Upanishad have clearly mentioned that in Hinduism, sexual intercourse is considered neither evil nor sinful nor dirty. Sex is divine, it's God made, and the basis of creation and preservation. The manifested universe itself is a product of union, because between male and female parts of the Supreme Being, who is believed to be both male and female in one cosmic body. We are all born out of sex. We are not fallen from the tree or stars. So why not talk about it? We talk so freely about piles, fissure, cancer, heart attack, this, that. But we don't talk about erectile dysfunctions, low desire, or early ejaculations, which are so common. The first education on sex was given by India in the form of Kama Sutra. It's not a book, it's not a pornographic book. It's a book where it teaches you how to make love. And historically what we see, we had drugs. But today, when you look at 2023, it's only OHS in diabetes and lifestyle modifications and nutrition. Today the things are changing in India. Gone are those days, we used to get our daughters married to a boy who's well-to-do, paise mein acha hai, meri beti khush rahegi, this, that. But that's not the case now. Women are empowered. They're earning more and equal to men. So besides financial insecurity, what do they want? Just think. What do they want? So that's the reason. And today what we see, lots of clinics. Even now, I appeal to Modi government to stop all this nonsense. Just so many clinics everywhere in India. And they advertise so boldly, even at the railway tracks, even in the newspapers, etc. Because a quick cure is a quack care. So beautifully said by Margaret Thatcher. Please understand the myths about sexual wellness and what are the facts. Some people feel that you only need to focus on physical health. No, you also need to focus on mental and emotional health, because it's always in the mind. Whether you are going to have it or whether you have problems, it's always in the mind. It's not in the reproductive organs. Wellness requires drastic lifestyle change. It's wrong. Small gradual steps can be taken to big improvements. Stress is always harmful. No, not all stress is bad, but it can be motivating. Sexual dysfunction is a part of aging. Sexual dysfunctions today can occur at any age. I have 20-year-old boy not getting erections because he watches a lot of porn. He's hardwired to the porn to get arousals, and when he's with his girlfriend, he doesn't get it because that whole scenario is not there. And what World Economic Forum says that we are going to live up to 150 years. Can you imagine? The study has shown. So how are we going to live longer, and how are you going to enjoy the more silver years? What is the key? And if we start getting diseases as we, so is aging a disease? No, it's not. We all sitting here are in a pro-inflammatory state. Anything going wrong in our lifestyle will put us into inflammatory stage. Will make our cells senescence. So how do we want to live our 60 plus gifted years in autonomy, dignity, grace, or be sexually happy, or disease, depressed, or dependent, unhappy, sexually starved, or emotionally crippled? What is our choice? What do we want? Dan Buettner, who went into 5 cities across the globe where people are living more than 120 years, he studied them. He found that these people were so healthy physically, sexually, emotionally, and having less chronic non-communicable diseases. What was the reason? Friends, sexuality is your fundamental right. It doesn't stop at 50, 60, 70, 80, but the recognition that older adults are sexual beings often does. The desire can be lifelong, not ending at any certain age. It's only when we don't discuss about it. Because sexual dysfunctions affects every individual and his or her partner, and there is a dent in the relationships for sure. Friend, when it comes to our body, which is a biological machine in action, diabetes and pre-diabetes is hyperinsulinemia, an inflammaging process. Diabetes is a sexual health tsunami of our century. Diabetes is, according to me, manageable metabolic malignancies. And there is a link between diabetes and sexual dysfunctions. All these patients, obese, hypertensive, sleep apnea, depression, and they take a lot of toll on your emotional health, changes in testosterone, estrogen, this, that. All obese patients who have visceral obesity, please don't give them testosterone. Just check their estrogen levels, because the fat cells which become enlarged convert the testosterone into estrogen. Moment you give them testosterone, again it's get converted with aromatase. So it's better to control obesity rather than giving them testosterone, which is not going to help. Their testosterone levels will never increase. So my advice is just do serum estradiol and find out if it is there, then counsel him to death to reduce his weight. And diabetics have impaired blood flow. Also, there are nerves which get affected. And coronary cardiovascular disease is a known complications of diabetes. According to ADA, adults with diabetes are up to 2 to 4 times more likely to have cardiovascular diseases, which is the biggest killer of today. Let me give you a new perspective. Coming to my talk, India has second highest number of diabetic diagnostic center across the globe. We have 1800 medical centers and clinics specializing in diabetes diagnostics. In this last 23 years, the number has increased from 567 in 199 to 1329 in 2022. And in 2021, 7 million people died globally as a result of diabetes, and so much of economical burden was there. IDF has stated its numbers, which are huge. ADA has mentioned there are facilitating positive health behaviors and well-beings to improve health outcomes in diabetics. This is 2025. They don't say that drugs help you. Behaviors help you. So failing to address the connections holistically risks incomplete care. If you don't address nutrition and lifestyle modifications, you're not curing, you're giving any justice to your patients. Perpetuating a cycle of illness and dependence on treatment that target symptoms rather than underlying cause, ultimately leading to economical burden for treatment of complications. This is a beautiful survey, diabetes care in public health in India. The doctor said, I have to see these many patients daily. There is no time available to maintain follow-up records and using the same at every visit. Many patients come here only for drugs. Only these patients who require specialized diabetes should be sent to tertiary centers or big centers. If we have to see 200 patients per day, then we can devote only 2 to 3 minutes per patient. There's a shortage of doctors. So lack of specialized training in these people also is a big cause. So to conclude, there is a wide gap between effective diabetes management practices today and their implementation at various levels of health facilities. The recommended strategy for diabetic care today, like self-management education, nutritional counseling, sexual health history and counseling, exercise prescription screening, are suboptimally delivered. A beautiful study. Just read. This cohort of thousands of men said that about 1 out of 3 cases of pre-diabetes and type 2 diabetes were made on the same date as ED diagnosis, and 75% were diagnosed within a year of presenting with new ED. That means ED came first and then the pre-diabetes or diabetes came. So new ED diagnoses are associated with previously undiagnosed pre-diabetes and type 2 diabetes. ED is also a risk factor for onset of pre-diabetes. So primary care clinicians should routinely screen for hyperglycemia when younger patients present with ED. So ED is a marker of undiagnosed pre-diabetes and diabetes. And it is proven beyond doubt that ED in diabetes is not just a symptom. There's compelling evidence that it's a risk factor for coronary artery disease. It's nothing but subclinical cardiovascular disease. So what are the options we have? How can we convert this small eel into a whale? Friends, the onus of sexual health of your patients lies with you, physicians. Your patients are not going to ask you. You have to come out of your clinical inertia and ask your patients. Very softly while examining or while talking, सामान बरोबर है, सब काम चल रहा है, everything. Say small, in your own way, in your own language, very softly ask him. That's all. He may say no at that time, but he'll remember my doctor asked me. Next time when he comes, he may address that issue with you. So how to set up an integrated, non-judgmental sexual health clinic in an existing diabetes center? That's the talk. First of all, please remember, don't do any harm to your patients. You're not supposed to do. You're not given the right to harm your patients. So don't scare your patients too. When you think of diabetes and sexuality, diabetes has a detrimental effect on the sexual functions of our patients for sure. Diabetologists who primarily care for their patients should not only focus on glycemic control of their patient, but also address their sexual complaints, because these problems can significantly impair the quality of life. Urologists, gynecologists, endocrinologists, psychiatrists should work in a multidisciplinary manner for treatment of decreased sexual functioning as a result of diabetes. So what is the rationale? There is high prevalence. India is the diabetes capital of the world. There's a need of ours is to integrate ED care into diabetes management, which is a must because we want to give them a holistic, good quality of life. Our goals are to improve quality of life, treatment compliance, and psychological well-being for our patients. So do we need certain infrastructures? But yes, we need. Everybody has an infrastructure, but make it little private, okay, with decent soothing ambience. Use a penile Doppler, lab support hormone studies, which is not difficult. You all can have a small lab in your, or you can have a collection center. Questionnaires, beautiful questionnaires. I will circulate that. I'll give it to Bansi Bhai. I brought the whole thing with me. And educational material for patients. I'll give you certain glimpse of my clinic, which is just going to come up. This is my existing clinic and my new clinic. Reception, just the examination room, waiting room. I don't want more people to be there. A couple can sit nicely, and a treatment room. So dedicated consultation room within the diabetic clinic. You don't have to have an extra. Your own room can be converted into a consultation. Privacy should be ensured. It should be soundproof, discreet, no entry possible, comfortable sitting, educational posters, patients' handouts in waiting area, being emphatic, very soft spoken, not to be judgmental, encourage the patient to speak and you learn to listen, make emphatic gestures to gain his confidence. Staffing, you don't need extra staff. No, I don't have to have 5, 6 people. No, not needed. You are a diabetologist, endocrine, initial screening and referral, you can do it. You can have a connection with urologist, andrologist, sexual medicine expert. Your educator who's already there in your clinic, she can screen the questionnaires, advise them on lifestyle. Psychological sex therapists, you can relate to psychological and psychogenic issues. Dietitian and physiotherapists can also counsel on lifestyle modification support. Patients during routine diabetes visits use questionnaires. All patients above 30 with history of metabolic syndrome or family history ask open stigma-free questions, evaluate with history, examination and all the lab tests. Do's and don'ts. Start with open-ended questions and never invite a negative answer. This is what Alfred Kinsey said. Never assure that what people know what words mean. Always start with a kind question, and I believe never confidently say that you will be 100% cured. Okay. So questions like, many men with heart disease experience problem with erections. Just a general thing. Don't make him feel that he's the only one. Sometimes when you take antidepressant medications, can notice certain changes in the sexual functions. Often men who smoke heavily have erectile functions, dysfunctions. It's common for men with diabetes. Do you have any of these issues? Very simple way to ask. Then give them certain, things like statistics. ED increases with age. Smoking doubles the risk of age. Men with diabetes have 3 times more likely to. So these statistics definitely shake them up. And what is the protocol? Lifestyle risk factors control should be the first criteria. It's been proven. Pharmacological therapies you can give, PD5 inhibitors, low dose. And of course, alternative therapies like vacuum, intracavernous shock wave therapy, surgical treatment, don't do it. Psychological support, you can do it. You can have a counselor in your clinic and can do it. So, what to do for your patient in your clinic, especially if he has ED? Screen him. Routine ED assessment in male diabetics, all about 30 years. Take a detailed history, do his studies, management, lifestyle modifications, optimize diabetes. Though being busy managing diabetes, try and ask him, does he have problems in making love? Counseling and referral to sexologist if needed. If need arises, you can give PD5 inhibitors, testosterone replacement therapy, but with caution. So these are the equipments. Questionnaires, you should keep it. Hand dynamometer, stamp test. I will tell you all in one minute. CBC, calculate platelet lymphocyte ratio, orchidometer, Doppler studies, lab for lipids, sugars, hormones, and age reader. This is a sexual health inventory for men. I will give it to all of you if you want. And this is how we diagnose severe, moderate, mild to moderate and mild ED. The another best way to find out is do a CBC and do a platelet lymphocyte ratio. If PLR is 104, he does not have any ED. If platelet lymphocyte ratio is 105, he's got mild. If it is 116, he's got moderate. If it is 136, he's got severe. Just doing simple CBC and doing a mental calculation, total platelets and total lymphocyte, iska 110, he has ED. And confront with him, he call you Sai Baba. Sir, how did you know? I never told you anything. Very simple. And it's not, you all do CBCs, right? So diagnosing is not at all a problem. Another test, neutrophil lymphocyte ratio also can give you the same thing. It's been proven beyond doubt. My stethoscopes are orchidometer. Very simple. I take an orchidometer, put it near their testis and just match the volumes. I come to know hypogonadism. Testosterone deficiency. I don't have to send him for free testosterone, total testosterone, which are so expensive. Very simple. And this orchidometer is available. And penile Doppler. These are two my stethoscopes. Hand dynamometer also can tell you your muscle grip is an indication of erectile dysfunction. Very simple to, you don't have to spend much. Dr. Bansi is giving free of cost to everybody. Then there's something called as advanced glycated end products reader, Just put a hand on this small gate, not expensive at all. And this can tell you severity of erectile. It can diagnose severe erectile dysfunction. Nocturnal penile tumescence rigidity test is a RIGI-scan. There are 2 electrodes which we tie at the base and the tip of the penis and make the patient sleep. And the computer records in deep REM sleep, if he gets normal erections, which last for 14 to 20 minutes, that can be plotted. If he has any organic disease, these plots will not be there. And that's a very easy way to diagnose. But it's expensive. I don't advise my patients. I give them a roller of stamps, free, which I get it from the post office. I tell them to tie it snugly on the shaft of the penis. If in the next morning it breaks, he's fine, he's normal. He doesn't need any medication. I save so much of money of his. And then I work for Bombay Police. I look at the cops. I look at the dropping belt sign. he's got ED, definitely. Simple. Belt देख के बता सकते. See, you wanted to tell me how to set up a clinic, not treatment. You should have told me to tell the treatment also. Okay, I'll tell you the treatment in short. I'll tell you the treatment. So, staff and patient education is a must. These are the posters you can keep. Erectile dysfunction is common and treatable. Restore confidence and restore intimation. There are lots of myths about premature ejaculation. It's not a disease. So, some important facts to be shared. Premature ejaculation is one of the most commonest problem with men. It's so common, more common than common cold. So it's not a disease. There are no tests for this, no CT scan, no sonography. It is when you feel it or your partner complains about it. And third, if you are having sex and sustaining for 10 minutes, at the end you ejaculate. If you are having sex with premature, you ejaculate within a minute. Again you are ejaculating. So your sex act is complete. It's not incomplete. If I give you an exercise which can extend your time of sustenance for 3 to 4 minutes, you're cured. So it doesn't need any medications. There are certain safe medications for you diabetologists. OHS you can give, but metformin and SGLT2 inhibitors, acarbose, imeglimin. Friends, these patients complain of weakness, kamzori. Don't think that because he's not performing sex, he's selling kamzori. No, it's the mitochondrial dysfunction which is happening. So give them imeglimin 1 gram twice a day. Low dose PD5 inhibitors, 2.5 mg of tadalafil can be given safely. Short course of testosterone in the form of gel, Androtas gel, 1% gel is available to be applied on a non-hairy portion once a day for 6 months. L-arginine, which is a nitric oxide donor proven beyond doubt. And fenugreek, which is nothing but free testosterone increaser. OHS can be given, and antihypertensives if you want to give, ARBs are the best. If you want to give beta blockers, nebivolol is the best. If you want to give diuretics, indapamide is a must. Statins are a must if he's got dyslipidemia. Follow up, document your results, business outcomes. If it improves IIF score, you have done it. There are barriers, lot of barriers. You know, the biggest barrier is embarrassment to talk about sex. Don't want to embarrass my patients. Don't know how to bring about the topic. No time to deal. The biggest question is time. You guys don't have time. You see 80, 90 patients. You don't have time for all these things. So there are obstacles. Doctors say, I don't have time. I don't know how to ask about ED. I don't make any statements about it. So there are ethical concerns. What is the ethical perspective? See, diabetes is an inflammatory disease, agreed or not. We all are in an inflammatory stage. And muscle is anti-inflammatory, fat is inflammatory. Okay, so to rekindle the sparkle of life, what advice you should give to your patient? Build muscle, burn fat. Build muscle, burn fat. Make a poster of it and do it. Medicine is not healthcare. Food is healthcare. Medicine is sick care. It's time we realize it. 2 times Nobel Prize winner, Dr. Linus Pauling, who gets Nobel Prize. This brilliant scientist, when he received his second Nobel Prize, he announced on the podium that nearly all diseases can be traced to a nutritional deficiency. What else you want? When scientists have discovered this, why you want to give drugs? And Cleveland Clinic proved that nutritional intervention in their study not only halted but even reversed coronary artery disease. So coronary artery disease comes later, ED comes first. So nutritional intervention you all have, you know the science behind it. So the art and science of sexual fitness, please advise to your patient is what you put in your body and what you do for your body. That's important. Lifestyle modification can reduce the pro-inflammatory milieu, insulin resistance, oxidative stress, endothelial dysfunction, and give the reduced burden of sexual dysfunction. So the holistic way to approach for firmer erection and your fractured libido is what? There is no happiness in medicine. There is no medicine like happiness. And being able to have sex is the ultimate. Friends, if you are able to have sex, your coronaries are clean. You don't have any coronary artery issues. You're not going to die of coronary artery disease, which is the common cause of mortality today. So my take-home message is, friends, aging is not inevitable. It's a relationship with yourself. Be proud of your gray hair, your wrinkles, your slack body. This is the age which you could reach. Many people don't reach at this age. So don't crib about it. Aging is not your enemy. It's your body's natural rhythm. How you age is in many ways up to you. You have a choice. Your skin, joints, endothelium, mind, our energy levels are reflections of your internal body. We cannot turn back and change, but we need to be very cautious. Rather than fearing the mirror, we can choose to see what our body needs. Everything is genetic is an old school of thought. You can change your genes today. Friends, you can you can decide the date of your death also. Aging is a conditions, and friends, don't we manage conditions? You can restore endothelial dysfunctions. So many strategies are there. Restore mitochondrial functions with just simple imeglimin. Nitric oxide, 50% you get it from endothelium. The rest 50% you can get it from beetroot, green leafy vegetables, nuts, pomegranate, watermelon, citrus seeds. These are nitrate-rich foods which get converted from your salivary microbe into nitrates and in your stomach into nitric acid. The third way is nasal sinuses are full of nitric oxide. So try to do deep meditation, deep breathing, etc. Chanting of Om also has been proven to produce nitric oxide. Dr. Nathan.
Oxidative stress and immune dysfunction. Nitric oxide corrects all of these. So how do we biohack to improve nitric oxide? The earliest stages of vascular inflammation are when monocytes and neutrophils start sticking to the lining of the blood vessels. This is the action of the spike protein. It activates platelets. The blood vessels become like Velcro. And we were able to
it's a real-time study.
In real time. So this is real-time intravital microscopy of an inflamed blood vessel. You can see the monocytes and neutrophils are stuck. There are a lot of cells that have already migrated through. So this is a heightened state of vascular inflammation from a poor diet. If we give that same atherogenic diet, but we restore nitric oxide production, the blood vessels are more dilated, the monocytes and neutrophils don't stick, they don't migrate through.
So it's a time to adapt. The need of today is my take home with love for the desire in you for making all your patients love. This is a profitable thing. Focus on increasing the patient volume. Impact through community engagement, target marketing campaigns. Establish insurance companies to pay for it. Most important, invest your time on counseling on nutrition, lifestyle modification for sexual wellness, which are the keys to improve endothelial dysfunctions, mitochondrial dysfunction, and nitric oxide. Have one day in a week afternoon time to appoint a radiologist, phlebotomist, and a sexologist, and call all your patients of sexual dysfunction with a regular weekly follow-up. Friends, my last 2 slides. Infrastructure, equipment, staffing, etc. is all manageable. Everybody can do it. They can spend money and have big infrastructure. But a detailed sexual history, education, counseling, and giving an emphatic ear and time is a challenge. But remember, it's a choice you have. You can do that. So in your diabetic center, please start taking sexual history, diagnose and treat. Because where there is will, there is a way. And nothing is impossible. I say, I can and I will. You need to have passion and change your mindset. Our Prime Minister, be passionate, fearless and focused, even in including sexual history taking and managing sexual, thus making your clinic a complete diabetic center. If you have patients, don't send them to quacks. वो सिर्फ पुंगी बजाएगा, कुछ नहीं करेगा. Send them to a good sexologist, you'll see that he gets a good erection. सदा sexy रहो. This is my book, Sex Has No Expiry Date, available on Amazon. Thank you all for your love.